Hi everyone, I was just giving everyone a couple more minutes to join in then, just to get numbers up on the attendees list and give everyone a little bit more time to get a drink before lunchtime. So just to introduce myself, my name is Kate Wakefield. I'm a medical affairs dietitian at VitaFlow, and I'm very pleased to welcome you to today's webinar, which is hosted by VitaFlow, the use of glycomacropeptide, or GMP for short, in tyrosinaemia. So before we get started, we just have a few housekeeping rules. So the webinar today will last approximately 60 minutes, and it will include time for questions at the end. So it won't be a full 60 minutes. There'll be time at the end for you to ask questions, and our webinar speaker today has kindly agreed to answer these at the time. If you would like to ask a question, please just use the question feature on your GoToWebinar toolbar. All the questions will be screened and a select number will be answered by the speaker at the end of the presentation. The webinar today is being recorded and it will be available on our VIA website in a few weeks' time. We'll let you all know when that is available with an email. You can access a certificate of attendance and a self-reflection tool in the handout section of the toolbar, which should be on the right-hand side of your screen. The views herein are of the presenter and do not necessarily represent VitaFlow's views. The material herein is accurate as of the date presented and for educational purposes only, and it's not intended as a substitute for medical advice. So, on behalf of VitaFlow, I am delighted to introduce our speaker for today's presentation, Anne Daly. For the majority of you, Anne needs no introduction. Anne is a specialist metabolic dietitian, and she joined the Birmingham Children's Hospital team in the UK back in 1995. She has been involved in many publications together with the small team at Birmingham, and in 2013, just to add an extra string to Anne's bow, she became a part-time PhD student at Birmingham University. And although the end of this PhD is in sight and the thesis is handed in, Anne still believes there are many more papers to be produced and new challenges to follow, and of course, one is never too young to learn. VitaFlow would like to thank our speaker for taking the time to present to us today. And without any further delay, I'd like to hand you over to Anne, who will continue with this presentation.
Okay, Kate, thanks for that introduction, and I'll begin. Just need to move on to the first slide, if that's possible. Can you move on to the first slide, Kate?
Yeah, do you have mouse control there? And if you just double click, it should.
Yeah, let's have a look. Brilliant. Okay, so welcome to this seminar, and today we're going to talk specifically about the tyrosinaemia pathway. And the question that we'd like to look at is, does GMP alter metabolic control and growth? And this is a 12-month prospective study. Okay, if you can move to the next slide, Kate, that would be great. Okay, I'm going to focus on the tyrosine pathway and the disorders, and I'm going to specifically be looking at the dietary treatment using GMP in tyrosinemia. So before we begin, I thought we'd do a little bit of history. So this is Leptosperum scorparium, commonly known as the mancuna, the bottle brush, or the tea tree plant. So why am I talking about this? Well, in 1982, Zenica Agrochemicals discovered that this Australian bottle brush plant contained a natural herbicide. They found that no weeds ever grew under this bush. And the reason why no weeds ever grew was that it produced a chemical substance called NTBC. This acted as a bleaching herbicide. It prevented photosynthesis and caused plant cell death. The company then did animal studies to see if NTBC could be used safely in the environment. And it was during these animal studies that they found that NTBC specifically inhibited 4-hydroxyphenylpyruvate dioxygenase, which is the third step in the tyrosine pathway. The animals, which were rats, had cataracts on their eyes, and therefore they decided that it couldn't be used as a herbicide, but the scientists in the plant lab collaborated with Prof. Linstead, and the very first patient was treated in February 1991. So if we look at the pathway, we know that we're very familiar with the very first enzyme, phenylalanine hydroxylase, leads to PKU. And of these enzymes, of which there are 6, there are 5 disorders. So the very second enzyme is tyrosine aminotransferase, which leads to tyrosinemia type 2. Sorry, could you go back to pathways, please? Okay, so the second enzyme deficiency leads to tyrosinemia type 2. The third step in the pathway, which is the 4-hydroxyphenyl pyruvate dioxygenase, is where tyrosinemia happens, and this is where NTBC blocks the pathway. We've also got alkaptonuria, and that's due to the deficiency of homogenistic acid. And then finally, tyrosinemia type 1 is the last step in this pathway, and untreated, that leads to hepatorenal disorders. And if we just look at the treatment pre-NTBC, 87% of these children needed liver transplant or would have died, and post-NTBC, that's been dramatically cut. So NTBC has been a great success. So what about the pathophysiology? So we've got these different disorders, and we've got a whole range of pathophysiological problems. In tyrosinemia type 1, which is a hepatorenal disorder, it involves the liver, the kidney, the heart, and the eyes. Type 2 is very rare and leads to very painful blisters on the eyes, the hands, and the feet. And these children have severe photophobia. Type 3 is normally associated with neurological problems. And then finally, alkaptonuria is due to chronic pain. But what about the guidelines and the recommendations for these conditions? Well, firstly, there are no recommendations and there are no guidelines for tyrosinemia type 2 or tyrosinemia type 3 because these are such rare disorders. Sorry, just need to go back, please. For tyrosinemia type 1, there have been 3 sets of recommendations. So what do these recommendations suggest? Well, firstly, that dietary treatment is necessary by a low tyrosine and a low phenylalanine diet. Phenylalanine is restricted because 50 to 70% of dietary phenylalanine is hydroxylated to tyrosine. A phenylalanine tyrosine-free amino acid substitute is necessary, and natural protein tolerance should be given to tolerance. And it's normally suggested that the target blood tyrosine concentrations should be between 200 to 400 for all ages, and target blood phenylalanine concentrations greater than 50, although these recommendations do change from country to country. So, specifically looking at GMP and its use in tyrosinemia, I'm now going to describe a 2-part study. So, we're probably all familiar with GMP. We know that GMP is a 64 amino acid polypeptide. We know that it's naturally low in a range of amino acids, particularly phenylalanine and tyrosine, and therefore suitable for PKU and tyrosinemia. And it's very high in threonine, isoleucine, and valine. Now, GMP, we all know, contains a small amount of phenylalanine and tyrosine. We know in our own work that when we've given GMP products to PKU patients, some of these children do actually cause phenylalanine concentrations to increase. And we wanted to ask that same question in tyrosinemia. So 60 grams of protein equivalent would provide 33 milligrams of tyrosine and 108 milligrams of extra phenylalanine a day. And is this an issue? If we look at the composition of GMP and L-amino acids, we can see they're very similar. If we give 20 grams of protein equivalent, we're providing roughly the same amount of energy. There is a slight difference in the carbohydrate and fat ratios, but overall they provide roughly the same calories and the same amount of protein equivalent. Now, we know that GMP has several functions. So we know it's a bioactive and it improves gut microbiota, promotes friendly gut bacteria, although this hasn't been exhaustively looked at in PKU or tyrosinemia per se. It's used in your toothpaste because it prevents tooth decay. It boosts the immune system. We know there are studies out there that show that it helps fight cholera toxins. And in our own work with PKU patients, there is a suggested improved growth and body composition when we've used GMP in PKU children. And that's when the children took all of their protein substitute as GMP. And there is also a suggestion that there's an improved phenylalanine stability over 24 hours. And again, this has been done in a PKU study. So what about TySphere? Well, TySphere is a complete protein substitute. It's got the additional of tryptophan, histidine, methionine, leucine, cysteine, and arginine. It provides 100% of all the vitamins, minerals, and micronutrients, and it's a berry flavored powder to which 120 ml of water is added. So what did we do as part of this study? Well, we recruited 11 children, and all of them had tyrosinemia type 1. In part 1 of the study, this was a very short day acceptability study, of which 9 children completed. So we looked at weight and height at the start and end of the 28 days. The children did weekly blood tyrosine and phenylalanine concentrations. We looked at the gastrointestinal symptoms, both pre-study when they were on L-amino acid and then at week 1 and week 4 after taking GMP. We also asked them about the ease of protein substitute and its acceptability. And then 5 children of that 9 went on to take the GMP for a further 12 months. And in that time, again, we looked at weight and height. We did regular blood tyrosine and phenylalanine concentrations, and we looked at its acceptability after a 12-month period. So our subjects, we had 11 subjects in total, 9 completed, 5 females, 6 males. The median age was 15 years, so these were all teenagers. And we all know that teenagers, particularly young adolescents, really struggle with dietary compliance. And we had a range of ethnic origins. So we had 6 were British Asian children, 1 Arabic, and 4 European children. All these children took 60 grams of protein equivalent. The median natural protein intake was 20 grams per day, although I will say this was never measured out, and I suspect was actually higher than this. None were taking phenylalanine supplementation, and all were compliant with NTBC. And succinyl acetones measurements were all, again, within recommended ranges. So what about the results? So if we first of all look at the short-term study, of which 9 children completed. And what we did was we looked at the tyrosine and the phenylalanine concentrations, median intakes 12 months before the study. And then we looked at the median tyrosine and phenylalanine concentrations after 28 days or during the 28 days. And as you can see from this slide, the tyrosine concentrations didn't change significantly and were in target range. And similarly, the phenylalanine concentrations didn't change significantly and were slightly below the target of 50 micromoles per litre. What about the gastrointestinal symptoms? Well, pre-study, 3 of these children complained of abdominal discomfort, 3 had heartburn, and 2 had nausea associated when taking their protein substitute. And after 28 days, 1 continued with abdominal discomfort, the 3 still described heartburn. But in 2 cases in particular, one child who had chronic constipation from an early age, and one child who had abdominal pain and actually was being reviewed whether to try some medication, those symptoms stopped when we started them on the GMP product. And similarly, the nausea associated with the protein substitute stopped. What about taste and smell in our 9 subjects? Well, taste was favourably accepted. In 67% said they liked the taste, and then 3 of them said they neither liked it nor disliked it. And then when we looked at the smell, again, more of them said yes, it had a nice smell, and 2 of them said they neither liked it nor disliked it. So what about our results over the long-term 12-month period? So again, this is just looking at the 5 children. So we did the same thing. We looked at the median tyrosine concentrations 12 months before the study in the 5 children, and then 12 months of taking GMP. And we can see in the 5 children pre-study, the tyrosine concentrations were above what we would expect at 490. This probably reflects the fact that they were struggling with their protein substitute intake and compliance. This had decreased, although this wasn't significant, it had decreased to 430 12 months on the study. And maybe surprisingly, and different to what we're seeing in the PKU population, the median phenylalanine concentrations, again, a not significant finding, but were higher 12 months pre-study and at 40 micromoles per litre post-study. Anthropometry, again, overall, there was no significant changes in height, in weight, or in BMI. So these children were growing normally. I want to spend a little bit of time just looking at phenylalanine because we know this is an essential amino acid. We know that deficiency leads to poor growth, skin rashes, and IQ delay. And over the years, there's been several studies specifically looking at phenylalanine and its relation to tyrosinemia. The very first study was done by Wilson in 2000, and he reported that 6 subjects had phenylalanine concentrations less than 20 micromoles per litre. And in that study, they systematically increased the phenylalanine concentrations to see what effect it had on tyrosine. And as the phenylalanine concentrations were increased, the tyrosine levels also increased. In 2013, in our own centre, we looked at 11 subjects. And what we found was that when the blood spots were taken in the morning, phenylalanine concentrations were absolutely fine. But when we took the phenylalanine concentrations in the afternoon, the phenylalanine concentrations were often very low, below 30 or even 20. So we know there's a diurnal variation when we look at phenylalanine, and therefore the timing of phenylalanine blood concentrations is very important. In 2014, Van Ville again reported phenylalanine deficiency in an infant at 6 months with tyrosinemia, showing the importance of looking at phenylalanine. And in 2019, another study from the Netherlands showed that the effect of various doses of phenylalanine supplementation on blood phenylalanine tyrosine concentrations in tyrosinemia patients. And it was this study that suggested that we should be looking at phenylalanine concentrations ideally over 50 micromoles per litre. So just to summarise, from the work that we have done, the residual tyrosine does not appear to adversely affect metabolic control. Maybe surprisingly, the residual phenylalanine does also not appear to improve the phenylalanine concentrations. And chronic gastrointestinal symptoms were resolved in 2 of our subjects. So to conclude, we found that the TySphere offers an alternative protein substitute in children who perhaps where compliance wasn't the best, and it was very well accepted. We do need to do long-term systematic studies on the interaction of GMP and gut microbiota. And maybe a thought for the future, somebody who wants to do a PhD maybe, GMP has shown to improve brain gangliosides, and they've used GMP in animal models, and they've looked at them particularly in the pig, where they've shown that giving baby pigs GMP has actually improved their learning capacity. And therefore, in my mind, would this action of GMP actually help in conditions where neurological damage is obviously apparent? And I know in our own centre, the majority of our tyrosinaemia type 1 patients have got a degree of neurological impairment. And therefore, my question is, should we be using GMP earlier, maybe as an infant formula? So thank you very much, and I will finish. Thank you, and take questions.
Thank you, Anne. That was great. We've had a couple of questions through, but I just wanted to firstly say thank you so much for taking us through the presentation and the study that has recently been done. The first question that we actually had submitted was in relation to the study. So will this data be written up and published? If you could take that one first, please.
I will take that one and say the paper is very nearly written up, and we hope to submit it in the next week or two. So yes, it will be written up. Thank you.
Fab, thank you. And the second questions come in to say, why do you think the GI symptoms in those patients resolved?
I think it has to be done to GMP, and we are doing a little bit more work specifically on gut microbiota and GMP, but we haven't got those results at all. The evidence is very overwhelming to say that GMP does have an effect on gut microbiota. It does alter gut microbiota, favourably so. But how and why and what actually bugs it benefits, we're at a loss to know. But what I would say in both of those children, particularly the child who had chronic constipation, what Mum said to me was she's never ever pooed as much in her life. Maybe that's not something you want to hear at 12 o'clock in an afternoon just before lunch. So it was, in a sense, quite an immediate effect. And I suspect it's down to GMP, but how and why, we've got to learn.
Yeah, it sounds like there's definitely lots more research to be done. And we haven't actually got any more questions come in. Has anyone else? Well, I'll put the floor open. If you could ask any questions via the question box at the side, here is your opportunity to do so. I have a question about, I suppose that obviously here in the UK, we don't have newborn screening for tyrosinaemia type 1. Do you think SPEAR would be more accepted in a country where potentially they do, and they're started on a protein substitute earlier?
I think it depends what time. It's not being used in infants, GMP. So, if you're doing newborn screening, whether GMP could be used in an infant formula, I don't know. And I think infant formulas, you have to be very careful, and they are very carefully regulated. And there is some literature looking at GMP in infant formulas, but there's also, I think, many questions that need to be answered before it can be used in an infant formula. So I think it needs to be looked at. I think there are questions that need to be answered when we look at infant formulas. I think what I ended on with about the learning capacity and the brain gangliosides is interesting, but to actually put that into practice, I think needs a lot of care and a lot of review, because we just need to be very careful when we're using infant formulas. So I think if we got the right balance and it was safe to use, then I think there is some indication that it could be used, but I think it needs a lot of careful research firstly.
Fab, thank you. And we've just had one more question come in to say, do you think the results will be different in a patient group who are more compliant with their regular amino acid supplements?
I don't think they would be different. You know, if that any child who's taking any protein substitute, if they're being compliant, the protein substitute works well, regardless of it being GMP or L-amino acids. I think what this did show to me was that you need variation. You know, there were some children who didn't want to take the GMP, so you do need to have an alternative. I think, you know, in these conditions like tyrosinaemia, in GA1, in HCU, the population of those of that group is much smaller than in PKU. So there isn't the alternative. You know, these children have the choice of maybe 2 flavors, and that is it. So I think, you know, the fact that, you know, you've got an alternative, you've got a choice is very important. Thai GMP won't suit everybody, neither will L-amino acids. But I think what we showed were the children, the 5 children who took it were the ones probably who were the least compliant. And by taking the protein substitute, their metabolic control did improve, although that wasn't significant. So I hope that answers the question.
Yeah, thank you, Anne. I think we've got a similar question that you might have just answered on the back of that, actually. So someone's asked if you could comment more on adherence to protein substitutes. Did you measure its self-reported adherence to the amino acid and then to the GMP? How was that measured?
We didn't systematically do that. But because we're speaking to the families regularly, they're sending in their bloods very regularly. And by talking to the parents, you know, they tell you, yes, I'm struggling to get the protein substitute into them, especially at 15 and 16 when the parents want to give them a little bit more independence. You know, because you've got a good relationship with the children and the parents will tell you if they're non-compliant. It is interesting because we did have one boy who in this group who did have some learning issues and some mental health issues, and he was very honest, and he would say, I haven't taken my protein substitute, I haven't taken all of it, and as a result of that his levels would increase. So yes, compliance is a massive issue, and I think if we can get them to take any protein substitute is a bonus. So anything that out there that they will take, fantastic.
Fab. And then I've got one last question, unless anyone else comes in with any more, because I know I've said that before, is do you have any theories to explain why the Phe level was lower on the group taking the TYR-Sphere or the GMP product?
No, I don't, and it does puzzle me, and it does in a sense baffle me. And just looking at all the work that has been done on phenylalanine, there is a diurnal variation, most definitely. And theoretically, you know, phenylalanine is being converted into tyrosine, but a group of children do need phenylalanine supplementation. And why that is, I really don't know. Whether it, you know, phenylalanine is an essential amino acid, so whether it's being utilized, you know, more rapidly than tyrosine, I really don't know. It's something to really look at and something to really think about. So I haven't got a definitive answer, but it's something that I have thought about, and I don't know why.
Yeah, it's definitely interesting because it is the opposite to what you would think, I suppose, isn't it?
Definitely, yeah.
We've got more questions coming in now for people under the pressure. So someone's asked, do you measure blood Phe and tyrosine on DBS or serum samples? And do your patients do blood sampling first thing, such as a fasting sample?
Yeah, so we do dry blood spots, so they just prick their finger and put it onto a blood card, and then that comes into the hospital. So we definitely do that, and we always encourage them to do them first thing in the morning. And the reason behind that is because the work that we did initially when we looked at tyrosine and phenylalanine levels, and the reason that we did that work was that when the children with tyrosinemia, they always used to come to clinic in an afternoon. And when they came to clinic in an afternoon, they had to have their big bloods done. And when the big bloods came back, I always got a phone call from the hepatologist saying, Anne, you're starving these patients. Their phenylalanine is 20. You know, they need more protein. And I would email him back and say, no, if we do their phenylalanines in the morning, you know, they're at 50 and 60. And so what we did was we systematically went back over our results and very, very clearly found that whenever we took the blood in an afternoon, their phenylalanines would be very, very low. But when we took them in the morning, they would be fine. And again, from that work, the Netherlands then looked at dosing of phenylalanine, and they found that, again, you know, to prevent that low dip, ideally you need to have a blood phenylalanine, you know, above 50. So yeah, that's basically to do with how we got into looking at, you know, phenylalanine levels and tyrosine levels, and why we do them first thing in the morning and not last thing at night.
Thank you. And we've got one more. Someone's asked if you could elaborate a little bit more on the possible mechanisms of GMP-mediated improvement of GI symptoms. Is it the gut microbiota, or are there other theories? I know you mentioned earlier there's more research to be done here, but
I think so. And without doing the research, I don't think we know. There has been research done. Denise and I has done research. There's an Irish group that have done research. Denise has done research looking at GMP and its effect on tyrosine and the tyrosine pathway. So I think there are many, many interactions. And I think until we do those studies, you know, the gut microbiota, there's trillions of microbiota and trillions of families. So I think it's a very interesting piece of work to be done, but it would need to be very carefully organized, and, you know, the methodology looked at very carefully to really decipher what's actually happening. So yeah.
Yeah, and
so
there's also quite a lot of there is research in terms of GMP outside of protein disorders as well, isn't there? And
yeah, definitely.
So it's
a
huge undertaking. But there's definitely people looking into that for sure. So I think in terms of questions, we're done. So I'd just like to take this opportunity to once again thank you so much, Anne, for presenting today. And we hope that the presentation has been informative and has helped advance your knowledge on the research that is being conducted in this area. So this concludes today's webinar, and on behalf of VitaFlow, we'd like to thank you for tuning in to today's session. Please take the time to complete the evaluation questions before you leave the session. And just a reminder, you can download a certificate from the handout section on the toolbar before you leave. So that's it for us. Goodbye and enjoy the rest of your day. And for those of you in the UK, have a nice lunch. Thank you, Anne.